because I'm on somebody else's screen now. Get it into. Okay, you can all see that, yeah?
Yes, yeah.
Okay, all right, okay. So the very first thing I'm going to say to you is about the Trinity Centre for Aging and Intellectual Disability at Trinity College. And it's important for you to be aware of this centre. When I was Dean of the Faculty of Health Sciences, I managed to convince the university that given the major issues around aging for people with intellectual disability, that it would be really great if we could have a dedicated centre for aging and intellectual disability. And we now have a dedicated centre in the university where you can go online, you can access all of the reports, the reading materials. Gavin will put them into the chat box, how you access all of those. So everything that we do, all the published papers, everything else is freely available for you all to download from that site and to keep connected. So it's the first dedicated centre to investigate key issues in ageing and intellectual disability across the life course. It's very much underpinned by the intellectual disability supplement to the Irish Longitudinal Study in Ageing, and that's called IDS-TILDA, and the general ageing study is called TILDA. So it's very important when you're talking about the disability one that we are called IDS-TILDA versus TILDA. And
the presentation's not moving ahead.
Oh. Okay. And am I in the second slide, Gavin, or the first slide?
It's the first slide, but it looks like it's loading. Do you want to maybe unshare and just go again?
Yeah, I might just get Margaret to see if she.
Okay.
Margaret, can I get you mind, because the presentation slides don't seem to be moving. So. No, they're not moving. Is that full screen, Margaret? Is that on the right?
Because it's gone to slide number. So what can the audience see?
The audience can see the first slide, I think.
Oh, right.
Is that right, Gavin?
It's still just on the first one for me.
Oh, right, because they're moving here for
they're
us.
They're moving here for us, you see. So back to the first one again, Margaret.
Do you want to maybe click unshare and share? Sometimes when you have it open up and when you've actually got it in slideshow.
Okay, stop sharing here, Margaret.
Stop sharing there. Stop sharing there.
Yeah. And I'll reshare again.
Start again.
Not just us to have these problems then.
Is that moving?
Yeah.
Just okay.
Thank you. Thanks, Margaret. So really the vision and the mission of the centre is to enhance the health and well-being and quality of life for people aging with an intellectual disability. And really the centre is all about trying to address the inequalities and the health disparities that occur for people with intellectual disability as they age. And we do this really by conducting rigorous research and engaged research on the physical and the social determinants of health and well-being and translating these into policy and practice. So we have a lot of international collaborations, as you can see from this. So we're working with other groups and countries around the world as we all work together to try to understand the determinants of health and well-being. And so from the very beginning, I always say research is everybody's business, including people with an intellectual disability. So we would have had a very strong public engagement and client engagement. So we would have worked with people with intellectual disability from the very beginning, inputting into the protocols, training of field workers. You may have seen Mei-Lin Yap, who's now working with us at the centre. She's a lady with Down syndrome, and she has produced a video, Aging with Pride, really talking about the 10 years of IDS-TILDA and the findings. And then it is all about translating. And here you see here Mei-Lin and Christina, and both of them now are working in the Trinity Centre for Ageing and Intellectual Disability on various projects. And I'm going to move now because the purpose really, so that just gives you an idea of what's happening at Trinity and how you can become connected to the IDS-TILDA study. So this here is a map of the world, and all the dots on this map really indicate longitudinal studies in aging that have been happening for the general population all over the world. So when the government in Ireland decided to launch a study of generic aging here in Ireland, I was very concerned that people with intellectual disability were not going to be included. And they had not been included in any systematic way in any of these countries. So I felt very concerned that we were very interested in understanding what was the key determinants for the like of ourselves as we age, but there was no effort to understand the key determinants for people with intellectual disability. Yet this population were living to old age. We knew that there was health inequalities, and we know that mortality is about 20 years, life expectancy is about 20 years shorter than we see in the general population. So I really got a group of a coalition of the willing at the time, back in 2006, to try to see, could we get a supplement to the TILDA study? Could we run a parallel study? And the study, the objectives are to understand the health characteristics of people aging with an intellectual disability, to examine the service needs and health service utilization of people aging, to identify the disparities in health status of people aging and compare them to the TILDA findings for the general population, and to support evidence-informed policies, practices, and evaluation. And I think the whole era of COVID has shone a light on the importance of evidence and evidence-based decision-making and evidence-based data. And it was by having data like IDS-TILDA that we really were able to mount with the National Federation and other groups to try to get people with intellectual disability moved up the list in terms of the earlier vaccination programs. And government and other groups heavily relied on the data, the evidence-based data that we had here to drive that. So that was really important. As I mentioned, we had a very strong values framework that have underpinned the study from the very beginning, and that was around the inclusion of people with ID, ensuring that everything we did was person-centered. We worked in a very empowering way, a way that would contribute to the lives of people, and really the people would have choice, and it would promote people with an intellectual disability. This is the conceptual framework that underpins TILDA, and as you can see, we're collecting data across a wide variety of domains: physical health, cognitive health, psychological health, behavioral health, healthcare, and social domains. And this is the same conceptual framework as TILDA are using for the general population. But you need to understand that TILDA is just one of a family of longitudinal studies all around the world. And all of these studies emerge from the HRS, the Health and Retirement Study in the US. And what countries are trying to do is to compare how people age, and so that we can understand the determinants of health and well-being in the general population. The areas colored in here in the blue color really represents unique measures or unique domains that we put in for intellectual disability. Obviously, you don't want to be changing what it is that we're doing, but because you want to be able to compare to TILDA. And once you change questions, you're no longer able to compare. But we knew that there was unique issues for people with intellectual disability, and working with the various working groups that we have involved in the study of people with ID, they helped us to develop unique areas and domains and questions that were important in their lives. And many of these areas are, you can see, reflected here. The TILDA study didn't really include anything around the social domains in the same manner as we have included this. And we have a sociologist, Dr. Dharma Cosland, who's a postdoc working with us for a number of years, who has published a huge number of publications and is working on this particular domain. So I think the beauty of this is we started this study in 2007. And really this was before the whole deinstitutionalization agenda, etc. So we have baseline data on what the health and well-being was like of people with intellectual disability prior to many of the policy initiatives. And now we're able to track how these have impacted on health and well-being for people going forward. So this, as I said, is a nationally representative longitudinal study on aging comparable to the general population. We start in 2007. Every wave is a 3-year wave, and we have just completed 4 waves. And the last wave was a COVID wave because we were out in the field collecting data in 2021. And you will have all, I think, and if you haven't seen the COVID report that we produced, you should download and you can access that from the website. We did have a major launch of that. We have collected a second round of COVID data, and we have all of the physical health issues for this population and the social health issues and mental health issues. So we are able to understand, well, how really COVID has impacted on people with intellectual disability who are older in Ireland, and how we need to support people going forward. And I mean, I think we have serious issues at this moment in time for people with intellectual disability. And given the very high incidence now that we have, we need to get back on track in terms of seeing, you know, will people again be targeted in the new booster vaccinations, and they're exempt from that currently. And I have a lot of concerns about that, particularly for people with Down syndrome, where we know the chronological age has little meaning in terms of the risks for poor outcomes should they get COVID. So we need to be driving this data to support that. And we will be launching our second COVID report in November. And I think it's really important that once we have your key people, Kate, that we can have their email addresses so that they're on our list if they want to be on our list, so that they know what events are happening and the series of masterclasses that we've been running, you know, all during the COVID pandemic, that people can join in. So it is a representative sample. They were randomly selected using we sought permission from the National Intellectual Disability Database, and I know that title has changed now. And we selected 10% of the intellectual disability population age 40. People, the general aging study, they enrolled people at 50 years of age, but we needed to enroll people at 40 because of premature aging, particularly in people with Down syndrome. So this just gives you a taste of some of the initial findings. And I've worked very closely with a working group from the National Federation, and I'm not sure if there's any representative from your team on that group, to try and see what these findings mean and how we can translate these findings to impact on services and change going forward. So these are some of you see here now we have, we refreshed the sample in wave 4. And we particularly, obviously 10 years on, those age 40 to 50 had aged out. They were now in the 50 to 60 year age group. So we needed to replenish that sample in that cohort. So our new participants are younger, as you can imagine, because they are mainly in the 40 to 50 year age cohort. So this is showing you the existing participants, and the new participants is in the darker blue. But all I just want to say is that chronic constipation in this population is a complete tragedy, really, in many ways. Major impacts on health and quality of life. Over almost 50% of this population having chronic constipation, many of them on 2 or more laxatives. And I'll talk a little bit about the prescribing cascade that we're seeing as a result of all of this. And even though these younger participants, the new participants, a prevalence of chronic constipation of 30% in this younger cohort is also equally concerning. Thyroid disease, as we know, is being higher in this population than in the general population. Gastrointestinal reflux, we can see here, is quite high in our existing population. Osteoporosis and poor bone health. This is Professor Eilish Burke is leading out on this area. And we had asked a question, have you ever been diagnosed by your doctor with osteoporosis? And in wave 1, when we asked that question, something like 10% said they'd been diagnosed. But I'll show you the slides. When we did objective measure of bone density in this population, the prevalence was much, much higher. Arthritis also at 20% are quite high, but really very concerning is the very high level of emotional, psychiatric and nervous conditions. At over 50% of the population having mental health problems and serious issues with medication and prescribing. Epilepsy, again, quite high in this population at over 30%. We know that the prevalence of epilepsy in the general population is about 1%. So this is also something that's quite unique to people with intellectual disability. So just looking at one or two of these areas in greater detail. So looking at bone health, falls and fractures. So here you can see here, doctor's diagnosis, as I said, at wave 1 was 8%, wave 2, 16%. And there's always a value in being involved in a longitudinal study. And much as we scientists might like to think that there's no intervention as part of it, there probably is a bit of an intervention, because when people ask you, oh, well, should I go for a DEXA scan or should I get my bones checked? Obviously, we are saying yes, especially if people have risk factors, you should. And you can see here that this doctor's diagnosis did improve across the waves. But in wave 2, I'll just get you to focus on the blue bar graph, 16% reported a doctor's diagnosis. And at that time, Ailish did a quantitative field ultrasound measure, the QUS, to measure bone density. And what she found was that 40% of the population met criteria for osteoporosis and 33% met it for osteopenia. And osteopenia, as we all know, is the stage before osteoporosis where people have brittle bone. And what osteoporosis is brittle bone, where people will really be predisposed to fractures. But many of these, it's a silent disease, and many people will have this disease and not know it. And yet so much of it is preventable. And there's many reasons that people with ID are a huge high risk for this, including the sedentary lifestyle, the diet, lack of physical activity, and indeed many of the medications that people are on also inhibit bone absorption. So this is a major silent issue that's of real concern and that we need to be addressing. And many people, of course, were not on things like vitamin D or calcium. Men also are at significant risk of poor bone health. So at wave 2, 6% of that population of men reported doctor's diagnosis. And on objective testing, we found that 90% of men who did not have a doctor's diagnosis had objective measurements of bone health. And again, there's lots of reason for this. So men with an intellectual disability in IDS-TILDA were 12 times more likely to present with osteoporosis than men in the general population, with data yielded by the TILDA study. And we're trying very much to get under the bonnet of this very high levels of mental distress that people have. And oftentimes we know that vertebral fractures happen very quickly when you have osteoporosis. So how many times have people perhaps other complaints that they're just not able to verbalize in a manner that people understand? And then looking at falls and the level of falls. And you can see here that falls and you have frequent falls. So in wave 1, we had 27% of the population had more than 12 falls. And in wave 3, that increased as well. 21% of this population reported fractures. But despite the very high rate of fractures, people didn't have a DEXA scan or a bone density scan. So these are all things that we need to be addressing, and we need prevention programs. I know we have physios on the line, but we need strength and resistance training programs for this population. And many people who are aging with an intellectual disability are all doing nice things. They're going to the coffee shop, they're going for a walk, but they're not doing many things that are really important and good for their health, both their physical health and the brain health, which I will talk about earlier. And here you can see as well, we did grip strength. And you can look here at the grip strength this is in wave 4 for people with an intellectual disability, the average for males and versus the average for females in the males in the general population. a 21 for people with intellectual disability versus 32 within the TILDA population, and this and difference also in those in the female population. So Eilish and her team have developed a very good program. It is Get Wise About Your Bone Health. And she got an EIT award to develop this. And this is an accessible online health education program about people going to the doctor. It has been done in collaboration with the Erasmus Centre in Rotterdam. People can access that bone health program. All of this information and materials that we've developed out of IDS-TILDA are all free. So you should be accessing, and hopefully you will find them helpful. We also worked with Age and Opportunity at the time, and this is Louise Lynch, who's also a PhD student, and she's particularly looking at sedentary behaviour. And what we found is, using the RAPA instrument, that 87% of people with intellectual disability were sedative or underactive. So they were leading a very, very sedentary lifestyle, which we know has implications for their health. We worked with Age and Opportunity, and this is Mariana Donovan and other colleagues here, and we developed what was called the PPALS program. This was the Physical Activity Leaders program, and we trained people with an intellectual disability to be physical activity leaders within their own community. And I'm not sure, and if you're not connected to probably the Trinity Centre and not connected, you may not be aware of the many things that are happening. But as you can see here, our efforts when we find things to try and address translational issues. This is Judy Ryan, and Judy is a nurse, and Judy has been looking at overweight and obesity. And again, very high levels of overweight and obesity in people with intellectual disability, and indeed in the general population. But what we have found is that those with mild to moderate intellectual disability are more likely to be obese. Those living in community group homes and with family were more likely to be obese. Women were more likely to be obese than men. And 56% of those who objectively measured as overweight or obese consider themselves to be the right weight. So we have a lot of work to do around healthy eating, around education, around lifestyle, because we know, and we have seen it particularly with COVID again, that obesity is one of the major risk factors in terms of poor outcomes, but also a major risk factor as people age, and many other health, cardiovascular disease, etc. I just wanted to move. Myra Dwyer is leading out from, she did her PhD with us, and she's a professor now in the School of Pharmacy and Pharmaceutical Science at Trinity, and she's leading out now on the Medicines Optimization Group. And this was just looking at a change in the prevalence and patterns of antipsychotic prescribing among the two nationally representative cohorts, aged 40 years over a 10-year period, 40 to 49 years. I'm very interested in intergenerational differences. So the people that were enrolled age 40 to 49, 10 years ago when we started IDS-TILDA, is there a difference now in the new people that we have enrolled, 40 to 49? And you would imagine, given all the changes and how much more informed that we are, that you would hope that you would see changes. So there's a real opportunity now with IDS-TILDA going forward to look at some of these intergenerational differences. And this here is a busy slide, but it just gives you a kind of a bit on the demographics and the clinical characteristics. So in place of residence, in wave one, we had 279 people aged 40 to 49. And in wave four, we had 128 people. And I think it is encouraging here because you can see here the change in residential settings. So those living now in wave four, that's the last wave that we've done, is the orange bar graph, and the blue is the previous wave back at the beginning in wave one, which was 2007, 2011. And you see now we have many more people, many less people living in residential care. That age cohort back in 40 to 49 in wave one, 44% were living in residential or institutional type care. And that now had reduced to 11%. So that's very positive in terms of what's happening. But in terms of antipsychotic exposure and overall use of antipsychotics, you can see here we have a huge issue with monotherapy and polytherapy. Monotherapy means one or more drugs, and polytherapy means multiple medications, indeed many interclass medications. So the maximum antipsychotics at wave 4 was 2, and the maximum in wave 1 was 4. So you can see here a reduction in the total amount of prescribing of antipsychotics in this population over the years. And that's something I think that is very positive and going in the right direction. And I think what's also very positive is the types of antipsychotic used. So the atypical or the newer antipsychotics, they're used more prevalently now than the typical antipsychotics in both waves, which is good. But there's a decreased use in wave 4 versus wave 1. So we know that the older antipsychotics, overall a greater reduction in their prevalence. They're less often used and fewer agents are used. So they are the typical ones that you see. You can see the blue bar graph in wave 1 showing the level of prescribing of those, and in wave 4. So this is positive because we know that the atypical, the newer antipsychotics are much less potent and are much less severe. While they have side effects, they are absolutely not as bad as the older typical antipsychotics. So again, looking at things like dementia and epilepsy in adults, and particularly those with Down syndrome, which has been an interest of mine for many years. Again, here you can see that the odds of a participant with dementia having Down syndrome was 10 times as likely as the odds of having dementia if you had an ID from other etiology. And this is really important. And you can see here the prevalence, and you will see the change in epilepsy or in dementia in wave 4. And this is because obviously the new people that have joined in wave 4, they're a younger cohort. And many of those, we have lost a lot of people from the population to death who have had dementia over that 10-year period. You can see here this very strong association with new onset seizure activity in those with Down syndrome when they develop dementia. And this is it. To the left-hand side is those with Down syndrome. To the right hand of this graph is those with ID from other etiology. So you can see here, those with ID from other etiology have a high prevalence of epilepsy regardless of dementia. But you can see that the prevalence of dementia is much lower. Those with Down syndrome, they generally don't have epilepsy until some people do, but we generally see it heavily associated with the onset of Alzheimer's disease. So what we're seeing is that approximately 70–80% of people with Down syndrome who develop new onset Alzheimer's disease will also develop new onset seizure activity. And this is an important issue for you and an important issue for care and how you're going to support people. The prevalence of epilepsy in the general population who develop dementia is about 11%. So you can see that the mean age of dementia in people with Down syndrome was around 54.7 years, a little bit higher than we see in the general population. But what we noted as well with IDS-TILDA, that many people with Down syndrome had never been screened or assessed for dementia. So we were likely to have a population again who were underdiagnosed. And there's a huge issue in terms of accessing service. So when we met with the National Federation and our working group, we felt that one of the biggest issues was around the inequity in access for people with Down syndrome in terms of getting a comprehensive memory assessment and a proper diagnostic workup for dementia. And we decided that we would try to tackle that. I've been brought out at Trinity 1 day a week since I finished my role as faculty dean for the past 2 years to set up a national intellectual disability memory clinic. I got seed funding from the Department of Health to the Dormant Account Funds to set up a pilot. I've set this up with Professor Sean Kennelly at Tala University Hospital, and Sean is the clinical director, and I serve as the executive director. And we did it in collaboration with the Daughters of Charity Disability Support Service, because they had a lot of experience in supporting people with Down syndrome over many years, and had a very well developed memory service and indeed a dementia specific service. So we brought everybody together. So this is a collaboration between Tala University Hospital, the Daughters of Charity Disability Support Service, and Trinity College. And I'm really pleased to say that I've been doing a lot of work on this in the last year. And in the budget announcement, you may have noted that there was specific money now been given to sustain the rollout of this National Memory Clinic. This clinic is free. Anyone can, you just send a letter to a GP if you want somebody referred. And we offer 3 types of services. People can be referred for a brain health assessment, which we do. This is for younger people with Down syndrome, where in their maybe their 30s, where people can come, get a complete workup, get a brain health plan done out for them, because what we need to be doing is moving in with prevention. Prevention is key for this population. We know that they have a genetic risk loading, so we need to be doing everything else that reduces risk. Then we can come and they can have a comprehensive diagnostic workup for dementia, including physical health assessment and neuroimaging, etc. And disclosure meeting then with Professor Kennelly and the team. And we have Dr. Jeanette Turl as well, who's a consultant ID psychiatrist, and 2 clinical nurse specialists and an advanced nurse practitioner who is also working as part of that. And then there is, people can refer where they have already got a diagnosis, but they want post-diagnostic advice or support. So there's different pathways, and what we need is a referral from your doctor, whether that's a GP or your psychiatrist or somebody else. That's fine. And of course, this is a free service. So I think this is really important. While we had very good pockets of excellence in some of the organizations, like for example, probably the Daughters, St. Michael's House, some other areas, but those services only seen people who are attached to their own organization. So for many people with ID throughout the country, they were not being seen. And what the generic memory clinics were saying was that they were seeing too few people with Down syndrome to have the clinical and other expertise that was required. So you needed to be seeing a throughput of patients. So the idea going forward for me is that I have this national clinic now set up. And in the future, I'm hoping that I will be looking at developing satellite centres and hubs in various parts of the country that people can access. And this is just moving down to another area, looking at older adults and choice and supported choice. And we've seen here that the level of choice has continued to improve between wave 3 particularly and wave 4. So level of choice in terms of day-to-day activities. So you can see here the basic activities of daily living. And I think there is a steady improvement in choices in other areas, like where you live, who you live with, how you spend your money. But in the earlier waves, we were concerned over how little control people had over their lives with respect to these areas. And these are all published here. So you can access all of these papers from just going on to the website and just downloading all of that information. And we also then looked at COVID, and just want to give you a brief update on what we found in the first wave of COVID survey, which was done between May and September 2020. And what that showed was that 55% of people with ID experienced stress and anxiety, 79% missing their usual activities, not seeing family and not seeing friends. So really, we are interested in going forward and looking at the longer term impact of COVID-19 on social inclusion and community participation and on the mental health. And we all know now that COVID is continuing, and we have very, very high numbers currently. And we will be looking at, we administered in conjunction with other people throughout the world as well, indeed, a COVID survey looking at where we looked at how people had fared in the subsequent waves. So we just finished data collecting in September of this year, and this is a wave 2 COVID survey. When it came then to things like technology, we had seen in IDS-TILDA in wave 1, it appeared that the technology age had very much bypassed people. But you can see here the very steep increase in technology use, driven very much in wave 4 by COVID. And this probably happened to us all. And I think if COVID did anything, it was really, looking at some of these areas. So really in wave 5, which we've now looking at starting hopefully in November of this year, was rolling out of wave 5 in 2022, we will be asking questions if these technology has been sustained and will access and continued use grow. And I think that was really a positive thing. In terms of, we have a very large arm, we also interview older family caregivers who are supporting people, their family member live at home. And Professor Damien Brennan is leading out on the family caregiving issue. We had I'm just giving you a very quick snippet of some of these issues, but I think we have had our eye looking at the deinstitutionalization of people with intellectual disability. And that was a very important and critical agenda. And we need to continue with that. But we also need to be very mindful of those who are continuing to live at home. And we know that very high numbers of people with intellectual disability are living at home. And the population we are looking at are older people with ID who are living with older family carers. And I'm just going to give you a snippet of what we found in wave 4. So we had 74 participants who were living with a family member. 80% were female and 46% were male. And really, this was some of the concerns and the worries that family caregivers had expressed. Where would she go if I wasn't able to care for her? What will happen when I'm dead? What will happen to him when we are too old to care for him? I worry that she will live longer than me. And as we do not have brothers or sisters to take care of her, I dread to think where she might end up. So these are real issues, and it's this type of data that you should be using as you're developing your strategic plans and as you're lobbying governments for support. We have the evidence and we're depending on services for the translation. And what about alternative care facilities in another area? What will happen? What will happen? He or I could get sick. He wouldn't be very patient. He would be hard to manage. What will happen if he gets bad in the head? If he and our health deteriorates, will there be a suitable nursing home? That he will be anything in the future will leave him in pain, especially he never complains. So these were real worries that family caregivers have. And again, as I said, IDS-TILDA was very critical in informed responses to the pandemic. And this is just from the survey 1 to survey 2. And I'm just sorry that these slides appear to have become a little bit misplaced. But really, I think Ireland did a very, very good job and are to be credited, all of the ID services and family caregivers, in how they managed COVID during the earlier waves. And I know it was extremely stressful and very difficult for all of you who were on the front line. But very few people with intellectual disability who were older, where there was grave concern and got COVID. So in the survey 1 of COVID, 10% presented with symptoms. In survey 2, which was done from May 21 to September 21, 18% presented with symptoms. In the survey 1, again, which is in 2020, 66% were tested for COVID and 76% were tested in survey 2, which was again in 2021. We had 2.5% tested positive in the earlier waves of COVID, and we had 9.2% of the total ID population. And we looked at over 700 people that tested positive. And I think this is a very good outcome indeed. 11% were hospitalized in wave 1, and 12% were hospitalized in the latter waves of the pandemic. 7.8% had moved residence in the phase 1 of the pandemic, and 10% in the latter waves of the pandemic. We had 0 COVID deaths in the population in the earlier stages of the pandemic between 2020 and September 2020. We had finished this data collection. And I think this is very positive indeed, given the fact that many of these had quite serious health comorbidities that would have resulted in poorer outcomes should they have got COVID, and really compared quite differently, contrastingly different indeed to what happened in the UK and the US for people with intellectual disability. So I really do think that ID services in Ireland managed the pandemic for people with intellectual disability very well. Since the pandemic started in 2020, we have had 3 people altogether who were enrolled in IDS-TILDA had died who had COVID. 1 definitely died from COVID, and the other 2 tested positive, but were at end-stage disease with other comorbidities, one with advanced cancer, I think, and the other with another terminal health condition. So again, we're looking at those who are vaccinated. We can see here that 87% of the population with ID were fully vaccinated, and this was up to September 2021. And again, as I mentioned earlier, again, it was stress and anxiety, which was really the biggest things for people. But people also identified good things, and it's important that we look at them as we begin to build back better. People felt they had more opportunity to do new activities, that they had more time for rest and relaxation, that they had more and better time with staff, and that they were able to use technology and communicate. And these were things that people felt was very positive. And again, we have a number of publications out on the impact of COVID-19 on people with ID, and you can access and down them. And hopefully you were able to join in the series of webinars that we organized from the Trinity Centre. We tried to run a series of masterclasses on a weekly basis to support ID services. And we had as many as 900 participants joined a number of those masterclasses. And there you can see we work very closely with the HSE again around health assessment, because we had learned a lot from IDS-TILDA and how to conduct health assessments with people with ID. And again, we work very closely with the All Ireland Institute of Hospice and Palliative Care, and we had over 10,000 people attend those series of webinars. And this is a quote from Alison, who's now the Chief Executive of the National Federation. So the evidence base provided to the research of IDS-TILDA team has been of enormous importance in grounding the collaborative work undertaken to ensure that the health and well-being outcomes of people with ID during COVID-19, and of particular importance with regard to the vaccination campaign, a key moment in making real our responses to Article 25 of the UNCRPD. So it is having IDS-TILDA was really the sole source of evidence-based data that we had, and we were very lucky to have that in this country. So I just wanted to talk finally before I finish up around end of life during the pandemic. And I'm, very connected to ID services throughout the country. And I understand the stress and anxiety that it was for staff in providing care. And this is a very busy slide, and hopefully I can take it through you. I'm able to take it through you. We looked at moral distress in paid caregivers during the COVID pandemic. So these were staff where we had interviewed, we did an end-of-life interview, who had supported people with ID who had died during the pandemic. Not necessarily that the people died from COVID, but they just passed away during the pandemic. And I looked at this through the lens of Barlam and Ramos' moral distress model. And I think it was a useful way for us to begin to understand some issues for staff caregivers. So really what this is showing you under the Barlam and Ramos model, and I have a paper coming out on this, and I will do a much longer talk on it, hopefully soon. But we all have a moral code about care. We all have our own idea on a concept of what good care means. So if there is a threat to that care, we usually begin to, we take on an advocacy role. Initially, and this is a quote from a staff member, initially had an argument with the doctor in A&E. I felt that they weren't listening to me. I felt that this person wasn't hydrated. I felt that there was something seriously wrong. So staff take on this advocacy role to advocate once they feel that there's conflict with their moral code with respect to caregiving. So if there's conflict with the code and they advocate and their concerns are addressed, things will generally go back. But if there is an obstruction, and as did happen with the restrictions imposed by COVID-19, they enter into what we call under this model, this feeling powerlessness. And these were some of the quotes. Nobody would listen to us. The doctor from the general hospital, the first time we went down, rang and was absolutely at the head of our director, sending down a service user in the middle of a pandemic. The doctor wouldn't come out and our own GP wouldn't come out. Everything had to be done over the phone. So this was this, complete obstruction. Staff felt powerlessness. And when they feel powerlessness in this way, in the moral distress manner, they enter into what we would call a chain of moral distress. And there is numerous types of moral distress. There's constraint distress. They're just constrained by what they can do. The conflict distress. I'm not sure if this is what I should be doing. I think there's a better way to do it. There's uncertainty distress. So under the moral distress framework, there's numerous types of distress, and people entered into this chain of this chain of moral distress. And then what happens is people can come into what we call this moral stagnation, and people then think, okay, they give up in a way. Well, that was a medical decision. It's not supporting what we would have done, but we did what we did. People enter in what's called reduced resistance. So they begin to feel, oh, well, there's nothing we can do about this, and this is the way things are. But there is an escape route out of moral distress, and that escape route very much is where people communicate very often with other staff for support, or they communicate with other resources, perhaps at the HSE or other areas have to move out of this code of moral distress. So people then begin to enter into what we call this moral residue. Oh, he didn't die from, it was COVID. It didn't die of COVID, certainly died as a result of it because she couldn't get the full care that she could have gotten, unfortunately. And we all believe that. So this was her wishes, and we had to respect her wishes, or this was the family's wishes, and we have to respect those wishes. So people, that is often a kind of an area or an escape route that people use, and there's a kind of an acceptance. And what very often happens is that people who have, entered into this code or chain of moral distress, even though they come out of, there is an escape route out of it, they often go back into it again should their moral code or conflict with their moral code of caregiving be threatened in the future. So at the moment now, that's just giving you a very quick overview of what we're doing. We have now, the government are very much our support, great support from the Department of Health and Disability and the Health Research Board, and we're now planning for moving forward with Wave 5. We will always be looking at, obviously you don't want to change the type of questions, but it will give us an opportunity to monitor new and key policies for inclusion. including the impact that COVID-19 has had on progress. And we will always review, we do a policy mapping exercise to see what are the key objectives set out at government policies at the UN, and are we collecting data that can answer some of these questions. And IDS-TILDA will continue to provide key health data to inform evidence-based health and social services for people aging with an intellectual disability. So having as many people as we can from your organization involved in this study is really key. We can do it, but we do need, and we're very dependent on the like of yourselves, I think, for help and support. This is my team, and I really want to thank this very growing and huge team of people now that we have from very, very diverse backgrounds. And of course, grateful thanks to the people and carers, to the various steering committees and scientific committees, funders, and to all of you who've been involved in supporting the study. Okay, so I'm going to unshare, hopefully. And it's not my screen, so I'm going to have to get Margaret perhaps to see where that is. Oh, good.
Yeah, no, thanks, Mary. It's very informative, and there's so much to learn and so much to do from it. Like while we're all working hard and doing, you know, what we think is a great job, there is so much more to be done. A couple of things just from my area that jumped out, like I think, you know, and I leave myself open to be corrected, like we have a lot of very, very good GPs, you know, and some maybe not so good. But I think in this day and age, it's sad to think that we have to go in and promote and chase to look for someone to have a DEXA, you know, DEXA scan or whatever. And then sometimes, I know from having a DEXA scan myself, you have to get up on the machine, let's say, and have it. But when you have clients who have complex needs or immobile, unless a lot of these places have hoists and things, they can't get up to have that carried out. You know, there's an awful lot hurdles in the way, I suppose, around those particular things. Even some GP surgeries might have steps up into it. So and when you go to have a client checked, you know, usually they probably say we'd have an annual medical, have a client reviewed or checked. You know, it's never forthcoming that it's suggested even, or saying I will refer Joe Bloggs for a scan, whatever. So unless we're in that frame mind to promote that, it gets overlooked unless there's a fracture or something. And I think, you know, it's sad to think that that's still going on the background.
That's and just to say on that, Gavin, if you want to stop the recording, thank you. And just want